Today, we are gathered with shared purpose to explore and delve deeper into public-private partnerships and collaboration models that can transform healthcare delivery at the county level across Kenya and permeate to the national levels. This session comes at a crucial time when counties face unprecedented funding gaps following reduction in official development assistance and shifts in donor support. It is also a moment to celebrate and learn from the remarkable success that has been achieved here in the county of Homa Bay. As we embark on this journey together, we acknowledge the traditional protocols and honor the presence of our distinguished leaders who have championed health reforms and stood tall in the face of challenges and public-private collaborations to ensure universal access to quality healthcare. This session aims to provide a comprehensive understanding of public-private collaborations, or best known as PPPs, to debunk myths, share real experiences from counties like Homa Bay, Tharaka Nithi, Nakuru, and Kajiado, and importantly, co-create innovative financing and governance structures that will sustain Kenya's health sector under devolved governance.
Let me just remind you that we lose a child every minute from malaria. So if changing that will come at the expense of my job, then it is a sacrifice I am willing to take. Ama namna gani watu yangu? Yeah. And I know for a fact for that to happen, we need a robust healthcare system, despite the challenges that we are facing. Juzi Muliona, the American government withdrew, but that doesn't mean that we should now sit and just wait to die. No. We must adapt. Yeah? We must adapt. And one way of adapting is exactly what we are doing here today. Fostering public-private collaborations that make sense, okay? And just by looking at the partners in the house tonight, I know for a fact that we have exactly what it takes and exactly who it takes to deliver us to Canaan. Sindio? So sisi as media people and storytellers, our work is to ensure that we shape the narrative, to ensure that whatever is discussed here is put into action.
Daktari Smart Telemedicine Program is a PPC by M-Pesa Foundation, Gertrude's Hospital Foundation, and of course, Homa Bay County. This is a hub and spoke model that is implemented in 5 counties, 6 health facilities. The 7th unit is a mobile unit that conducts outreach all across the 5 counties. In Homa Bay, the telemedicine project is implemented in Super South sub-county. This project targets people from the age of 0 to 21, and I'd just like to draw your attention to the fact that we have 44.2% of the population at 65,700 under the age of 15. So very, very many people targeted by this program. The program was launched in 2021 to improve access to specialist services in rural and underserved areas. It uses technology to deliver consultation and care in real time. This project offers specialized pediatric care. The most sought after is hemato-oncology and dermatology. This project has helped to strengthen our healthcare system. It has improved our health workers' knowledge of pediatric care. Our community mobilizers are well-trained and well-versed in care for children. And there's been a lot of advocacy with local stakeholders improving the quality of care for children.
Every 2 minutes somewhere in the world, a child dies from malaria. For decades in the Lake region, the statistic was not just a number, it was our reality. Families here buried children before they ever celebrated their 5th birthday, and expectant mothers lived in constant fear. But in Homa Bay, we have decided a statistic will not define us. Kenya is a nation of immense beauty, resilience, and potential. Yet within our borders lie stark disparities in the health burdens our people face. While some counties have successfully eliminated malaria, in others, especially in the Lake region, it remains a relentless public health emergency. In Homa Bay and across our neighboring Lake counties, malaria was for decades one of the leading causes of sickness and death. The most vulnerable were always the same: children under age of 5, and expectant mothers. Every case was more than a statistic. It was a child missing school, a family pushed deeper into poverty, and a dream interrupted. When I assumed leadership, malaria prevalence in Homa Bay stood at a staggering 17%. It was clear that business as usual would not be enough. We needed urgency, innovation, and unity of purpose. Today, I'm proud to say that through collective action, deep community involvement, and unwavering support from our partners, we have brought this figure down to just 3.6%. This represents thousands of lives saved, hospital beds freed, and communities thriving. This success did not happen by chance. It is the product of deliberate, targeted interventions that reached every corner of our county. Mass distribution and timely replacement of insecticide-treated nets, IRS in high transmission zones, strengthening diagnosis and treatment with rapid diagnostic tests in even the most remote facilities, and a robust community health strategy, empowering local champions to lead prevention, early detection and treatment, and strong surveillance and research systems to anticipate and respond to outbreaks.
When I heard Her Excellency talk about malaria, it took me back to the 1980s. Malaria was such a dreaded disease because, for one, if you'd get it, you'd fall sick, isn't it? And then there was these drugs that were brought into the market. Taking them was also another dreaded episode because they were too bitter to swallow. And then lastly, after swallowing, I don't know what Dr. Jikal did to those drugs. You'd sit in a corner and wait for your body to do what? To itch. That was malaria queen, chloroquine, and such like. So, Daktari, you will tell us what you did with those drugs to make us itch. So, taking us back to what has brought us here today, as I've been introduced, my name is Engineer Kefa Seda, Director General at the PPP Directorate at National Treasury. And I'm happy today to participate in this discourse, speaking about healthcare, collaboration between public and private entities in healthcare systems. It is both an honor and a privilege to join you today for this important session on the institutionalization of public-private partnerships in healthcare across counties. First, I would like to express my sincere gratitude to Open Phences for inviting me to contribute to this crucial conversation on healthcare within our devolved units. I would also like to commend the Council of Governors for organizing the Evolution Conferences, which is a vital platform that fosters collaboration, idea sharing, and innovative solutions among counties. The theme of today's session, healthcare, financing, equity, and inclusion, lies at the very heart of our ongoing journey to devolved governance. As we face challenges of shrinking fiscal space, and this is something that we speak to on a day-to-day basis, and mounting unpaid bills, the goal remains clear: to ensure affordable, accessible, and high-quality healthcare for all. In times when both national and county governments are grappling with these financial constraints, our commitment remains unwavering. Every Kenyan, regardless of geographical location or economic status, must have access to quality and equitable healthcare services.
One of the things that you're going to see as these sessions continue is counties are doing amazing work when it comes to partnerships, but one county does not know what the other is doing. So what we are doing here, Your Excellency, is a statement of intent to establish a mechanism that allows counties to learn from each other on public-private partnerships and investments so that they don't repeat the mistakes. Because sometimes what happens is this one has done this, they made the mistakes, they corrected it, and then somebody else starts and they start from the mistakes. So this is just a way of actually getting that commitment out. But the most important thing in this commitment is we are proposing, those of you who are familiar with the National Council Law for Science and Technology Act, it says that 2% of GDP should go towards learning and research. What we are proposing here is, as partners who work with counties and government, can we progressively aim to allocate at least 2% of project value to support learning and discussions towards scaling, so that we stop doing small things and then moving away. So as partners, we can actually have some resources put aside. So it's purely a symbolic signature to support the county, the Council of Governors and partners to establish a joint learning mechanisms for PPPs.
So I think one of the ways of leveraging the expertise of the private sector is in terms of developing framework contracts between counties and private vendors that can complement KEMSA during, when they have stockouts and so on. So there are very many opportunities for us to really tap into the private sector. But for this to happen, I think autonomy is really critical, that facilities have financial autonomy to retain the resources that they get from SHA, so that they can be able to contract private facilities. And they also need to be clear contracting frameworks, and our colleague from Treasury has all that. So I think we already have the enabling legal and regulatory framework. It's really for us to step forward.
A number of things. The first is for all of us, and especially those in government, to figure out that you will never have enough money for healthcare from KRA. It's just not going to be enough. It doesn't matter how you share the revenue. It's just never going to be enough. You have to be able to access private resources for operations and for capex. And KRA also gets money from private resources. It's just one of the channels. That's the first recognition. The second one is to recognize that unless incentives are tied to output, all the patients who come to your facilities are a nuisance. The longer the queue, and I worked in Kenyatta, the more of a nuisance it is, unless there is a correlation between my interests and the interests of patients. And that's where private-public collaboration becomes very, very useful. The third is that the entire health sector is a private-public collaboration, as it is. We just need to improve the legal framework and the governance. But everything we've done since independence, whether it's KEPI or COVID recently or whatever else, it's always been the private sector, the public sector, the non-state actors working together. We just need to make it work a lot better.
What I would like to say is maybe we still need to have a lot of conversations between private sector and the executive, because we think we in Parliament has provided the legal framework for private sector and public to work. That's why we have a PPP Act in place. We have a Social Health Insurance Act in place that can pay for services used by the public, both in public and private facilities. The conversation should be at the implementation level. What is it that the executive in the county and at the national government level can do with the private sector in terms of implementation and collaborate? Number two, one of the things that I think in my view has been a bottleneck towards having a successful public-private sector collaboration and initiatives is the transparency involved in the processes, both from the government position and also from the private sector. There's a lot of hoarding of information and resources, both in private sector and government. And I say this because, for example, you find a manufacturer who has a good product, has only one agent in the entire continent of Africa, who everybody is running after. That agent is not willing to share that agency with any other agent. So you need him in Tarakanidi, you need him in Omabe, you need him in Uasin Gishu. He is not available. He is holding into a very important innovation that would have been easily shared and spread and used when we are looking at the least cost provision of service. So I think one of the things that we want to encourage is transparency in all these processes.
The first thing I wanted to mention, and again to support and build on what my colleagues have talked about, is that we need structured dialogue and engagement between the public and the private sector on an ongoing basis. And I'll give a reason why.
Dr. Gakombe here knows we spent many years setting up the ministerial stakeholder forum, presidential roundtables. I don't know that we have governors roundtables to really hold each other accountable. I've heard Senator Mandago talk about transparency. How do we hold each other accountable for the public-private goals that we have set before us? How do we identify which partnerships really will give us value for money, value for health, and are in the public interest? That discussion needs to happen. Second thing I would mention is the role of innovation. Dr. Gakombe has mentioned about least cost way of delivering care. Innovation is about improving the impact or the outcome of our health interventions while using the least amount of resources available. But innovation is also about providing care that is acceptable, that is good quality, that meets the felt needs of the communities we work with. So we need to think very innovatively when we talk about partnership. We should not partner to bring in mediocre and old ways of doing things that are expensive, that are very costly.
First of all, I started work here in Homa Bay as a medical officer. When it was clear to us that if a woman got into labor at 2 o'clock in Sindor, in Beta, she was likely to die. And we even had to have boat ambulances, motorboat ambulances. And when I became Director of Medical Services, we said some of these things should be corrected. And we had to get the hospital in Sindo, the hospital in Migori. Before then, the only hospital in Migori was Ombo, which was a private hospital at the time, and the hospital in Karachuonyo. What I learned during that time is that the health sector is one. The distinction that it is private and public is just because of management and the source of funding and a little motivation of interest in the part of the private sector. That money in the health sector, we need to put it all together, whether it is in the public sector, whether it is in the private sector, and how can we best use it. If you do that, we actually have enough money. If you do it what in the health sector and what in the private sector, what happens with inefficiencies and also self-interest, you will find that the cost, at least before, in the in the private sector was so huge that what would treat one person in the private sector would have treated many people in the private sector. When you come to the private sector, the inefficiency is so much that the money that is lost in the inefficiency. So that is the first thing. So people at the high level like us should actually realize that whoever can do it best should do it. I think that is the essence of that. Number two, of what I've realized, that health sector, like any other service, is actually delivered through politics and business. Whatever you do, those two things will actually run it. And what we must try at all times as human beings, guided by laws, is that business interest and political interest can only be tamed by us in the health sector, so that business interests and political interests do not erode the services that we give to our people. Having said those two things that are very difficult, my other realization is that we actually work in silos. The counties work in silos, and I think many people say that here. Then you also find that the private sector is also working in silos. And then you have another silos now in the public sector, not county to county, but national government and county. because all these are partners. So in my view, what we really need to do is actually get partner coordination mechanism. And there are various levels of this partner coordination mechanism. The first and the biggest one is actually between the national government and the county government, because even there are a lot of coordination that is required.
A special thanks to Liz and Abel. I know, we ambushed you, but you've actually stepped up for us. So thank you, and thank you for everybody else who's participated in this as well. Thank you.